I'm Shawn Hayden, like Melissa said. I work on the RCORP grant, similar to the one that Felicia will be talking about. And it just happened to coincide that I was working on my doctoral research while working on this project. And so everything kind of worked out pretty well in me also focusing my research on providing medication for opioid use disorder. So I'm going to kind of go over my research and then kind of circle back and explain how with the RCORP grant, we can utilize hopefully some of the results that I found in increasing the access and availability of medication for opioid use disorder in Missouri. I don't want to go super in the weeds on this. So if I go too far in the weeds and anyone has questions, please like raise your hand or do something via Zoom, or even unmute yourself and ask a question. I'm totally cool with that since I have an hour to talk. So my study's title was The Relationship Between Medical Provider Continuing Education, Potential Barriers and Attitudes in Providing Medication for Opioid Use Disorder. It was also pretty timely with COVID and everything, as there were some changes in policies in regards to prescribing medication for opioid use disorder. And so I will hit that on later slides. But the focus of my research was, like I said, to examine the relationship between continuing education that medical providers receive, the barriers and attitudes that they have in prescribing medication for opioid use disorder. I focus this around the research question of what is the relationship between provider continuing education and the potential barriers towards treating opioid use disorder, specifically in rural Missouri. The Cox Health Service region is primarily considered rural, so I wanted to make sure to lump that in. I'm not going to go through all my hypotheses, but there they are right there. And then the two research questions that I had at the bottom were also a big focus. To what extent do the perceived barriers in prescribing medication for opioid use disorder discourage providers from addressing substance use, as well as what factors are associated with continuing education for opioid use disorder contribute to the negative attitudes in treating it? I got a lot of good responses from providers, specifically on those last two, and I'll circle back to those whenever I get the results. So whenever I was working on this, I dived deeply into the literature that was already available. And there's a lot of research out there on the barriers that attribute to limited prescribing of medication for opioid use disorder. A lot of it revolves around the policies, the stigma, the lack of training, the lack of provider education, the poor care coordination, and the regulatory hurdles for those who are prescribing in a non-addiction specialty treatment setting. And that research was done in 2018. The research also indicates that independent of location, providers who are addiction specialists do not prescribe medication-assisted treatment to the limits that they have because of lack of experience in working with substance use disorder patients. And there is sound research on prescribers' negative attitude remaining a barrier in adopting and implementing medication to treat opioid use disorder. The study by Louis et al. Really focused on the self-efficacy that providers had and how that impacted their attitude. To kind of circle back on this, I did my schooling at A.T. Still University College of Graduate Healthcare Studies, and we had to do a education component along with this. And so I was trying to see what next slide I had. This slide I had next, sorry. And so I kind of took all of the MOUD literature that was already out there available and compared it to Malcolm Knoll's 4 concepts of andragogy, which is education for adult learners. And there was a really sound alignment between the literature on provider barriers, self-efficacy, attitudes, and things of that nature, as well as the concepts that are needed for adult learners to learn new skills and apply them. And it aligned really well with physicians because the 4 concepts that Malcolm Knowles outlines are basically around the concept of learners being dependent and self-directed human beings. Learners have to accumulate a growing reservoir of experience that becomes an increasing resource for learning. Learners have to be equipped with the readiness to learn and become increasingly oriented to the developmental tasks of their social roles. And learners' perception of learning changes in time, especially with the intimacy that they have to the application of what they are learning. And when we think about physicians who are learning a new skill, specifically that of prescribing medication for opioid use disorder, there are a lot of hurdles that they have to go through regulatory wise. But when they get this new skill, they want to be able to apply it quickly, timely, and within the setting that they have. And so having this concept of being able to be self-directed and get the information and apply it directly comes up a lot later in the research that I conducted, specifically whenever I was interviewing providers and how they didn't have the setting of being able to apply this stuff, specifically in regards to care coordination. And so we've all been battling COVID one way or the other. And so MOUD during COVID has changed quite a bit also, with increased telemedicine. That has seen both positive and negatives, and I'm really excited for future research to see how telemedicine has impacted, the overall concept of healthcare in the future. The study by Ursher Pines noted that for those who have literacy, technological literacy, telemedicine was a huge benefit, and that it actually increased patient retention to treatment, but there's barriers to be there. Specifically in our RCORP grant, technology is a huge issue. We had one partner who went out and purchased like a swath of iPhones for their patients, all with data plans because internet was a problem. In other rural areas, I mean, that's not possible. The DEA has also granted exceptions with regards to MOUD treatment during COVID. Also in regards to telemedicine, so prescribers in states where the practitioner is not DEA registered can prescribe there. And opioid treatment facilities can use site locations in the same state where registered to deliver take-home doses of methadone to patients without separate registrations. OTPs had a lot of issues early in COVID, and so the DEA working with them on these policy changes has been very helpful. I just noticed something in the chat. Okay, that wasn't for me. So the study methodology that I utilized was expanded upon by the study by Andrea et al. At the University of Washington WWAMI Rural Health Center. She did 3 studies gathering data through questionnaires and interviewing rural medical providers. And so I took the same methodology after I got approval from her. And then I correlated it against Bandura's 4 stages of social learning and Malcolm Knowles' 4 stages of social learning. Like I said, approval was given by the WWAMI. I did make one change to the questionnaire. It'll show later in the slides, but there's a whole section on barriers that providers run into. And I changed that to a Likert scale for reliability and validity in the study. The questionnaire was used to gather quantitative data on the independent variable of medical provider barriers, and then interviews were used to gather qualitative data on the provider's attitudes and barriers, the dependent variable. And then also I used that to elaborate further on if continuing education had an impact in their availability to prescribe medication for opioid use disorder. And now, okay, there we go. So my samples populations came from the Missouri Academy of Family Physicians, the Cox Health Family Medicine Residency Program, and the University of Missouri Rural Scholars and Community-Based Faculty. Like I mentioned before, this was a pilot study utilizing a amended questionnaire that was already been published. And so I calculated the Cronbach's alpha coefficient to ensure validity. And even though this tool was used by the WWAMI previously, I just utilized all the data collection measures that they already used to ensure internal validity, and that was achieved. I need to make sure my notes on this next section are pulled up because I didn't want to bore everyone with a huge amount of result slides. Okay, cool. So it was done during COVID, and physicians were inundated with a ton of things outside of responding to my request for participation. And so I reached out to over 3,000 providers, and I love the 68 of them who responded. And so from the data that I got, 77% had not prescribed MOUD, and I broke down the population who participated by the Missouri Health Net regions, and almost 63% were from the Southwest region, which makes sense. I relied on Cox Health a lot to help me, as my data did not trickle in as fast as I wanted. And so that's where I'm at. So that correlation makes sense. The majority of the participants were from a community health clinic or from a hospital-sponsored clinic. Like I said, a majority of them were not prescribing MOUD. 20 was the maximum amount of physicians who had waivers in the clinic. 45 was the maximum amount of physicians in practicing at a clinic, and only 2 participants were taking on new opioid use disorder patients. If we look ahead, you'll see on the left-hand column the barriers to prescribing medication for opioid use disorder. The number one, was the lack of availability to mental health or psychosocial supporting services. Number 2 is the lack of confidence in your ability to manage opioid use disorder. And then number 3 was the lack of specialty backups for complex problems. From the barriers, I calculated the Cronbach's alpha, and I got a significance of 0.645, which, based off the statistical analysis, that shows that it was valid. So amending the new tool produced valid results. Overall, even though I did not achieve statistical significance through a linear regression and my p-value through the ANOVA, I got a p-value of 0.043, and the f-value showed significance. As I mentioned before, I reached out to, the total amount was 2,790 individuals, and my rate of completion was 59%. The response rate was 2.4%, which was not what I wanted, but what can you do when you're working from home and there's a global pandemic going on? And like I said, whenever I looked at my independent variable of barriers to prescribing MOUD, the significance was there. And it really showed not only with my p-value, but also with my frequency, specifically at 1 in 37, which was 4.379. And that showed on the ANOVA scale on the bottom right-hand corner. For this study, there was an overarching assumption that participating physicians were aware of the steps needed to be waived in prescribing medication for opioid use disorder. That might have been a broad assumption, and in my limitations, I note that needs to be considered, because one participant, when interviewed, said that they did not understand what was needed after they finished the course to prescribe MOUD. A direct quote was, "I remember doing a follow-up and there was an online thing, whether it was a test or just clicking a button, and then I didn't do anything else. So this individual sees 0 patients and another provider in her practice has 1. And a direct quote was, "I don't think that they were actively advertising because of the hurdles from questions, interview questions 1 and 2, which that doesn't make sense to you guys, but this assumption probably wasn't good, in that a lot of the providers that I interviewed, the act of going to the classes and completing the work was a barrier in itself." And this is shown, the barriers cross tabulation right there doesn't show a ton, but the regression analysis of the Health Net regions and those who prescribe MOUD shows a direct line, essentially noting that those who work in rural communities have greater barriers, specifically in care coordination and providing mental health services. One of the participants that I interviewed said a direct quote of, whenever I asked specifically if they saw any ethical contradictions to them prescribing or not prescribing medication for opioid use disorder, the quote was, "I think it's well to say to those patients who legitimately want help, if I'm not serving them, if I cannot prescribe what they need and I cannot coordinate the care, and I don't have the knowledge or training, it is not an ethical contradiction. Do I feel like it's unethical? No, I wouldn't phrase it as unethical. It's just more of the knowledge base to take care of. I guess, it's pie in the sky. If there could be, say, a super clinic and 2 providers in the clinic who were trained and knew that they were the go-to people for opioid use disorder, that would very much be ideal." And so even though I didn't reach statistical significance with this, and I only was able to interview 5 prescribers, none of which who were prescribing medication for opioid use disorder, and were very, I was very lucky that they were very forthright in their thoughts on the practice. The data still is valid. And so, like I said, I came across a lot of limitations, and there definitely needs to be future research done on this. COVID-19 was a huge barrier. I saw Kathy in the Zoom room before I started presenting. I know I emailed her a ton to help me get participants, and she did all that she could. Only 68 participants did not reach my statistical significance. From my calculations, I needed to hit 114. So I wasn't even really in the ballpark, just to be honest. I also had a delimitation in my study design, in that my primary population was only primary care physicians. This excluded other physicians who were waived, as well as nurse practitioners and PAs. And the A should be capitalized, not pause. I think in future research, the evaluation of interview questions should be considered. This is my first time really drafting interview questions for a research study that was aiming to be published, and that was a ton of stress on me. And I realized as I was collecting data that there was a lot of overlap from an interview question that I was asked, and then like a previous interview question. And so there was some redundancy. And that was just from lack of experience. So I don't need to be too hard on myself when it comes to that. I think the tool that Andrea and her research team utilized was great. The tool needs to continue to show consistency and reliability. Since my Chromebox Alpha was 0.645, my p-value was less than 0.01. And my frequencies were significant at 4.379. You know, and further on in other ANOVAs, it shows significant at the degrees of freedom. The validity is there. It just continues to need to show reliability. And so, like Melissa said at the start, that I am one of the RCORP grantees. And so, how did this help me in my grant? I haven't shared my results with HRSA yet, but I think it showed that there's a lot of potential in our region. Specifically in the region that I serve, the Cox Health Service region, we have 27 counties, and there's a handful of providers who are prescribing medication for opioid use disorder. The barriers that they face are the ones that was mentioned in my research. And here's a great quote from one of the providers that I interviewed. One of the physicians, this was their view on how addiction impacted attitude. It says, continuing medical education should have components which remind providers that no one wants to be addicted to medications or other drugs, and it's as much a medical illness as it is a mental illness. And the barrier of treating these patients, of not knowing what to do, of not having the care coordination, really shows that we need to further educate providers on what's out there, be it in a means of self-directed learning or in the experience that they have. Because a lot of them, if you ask them, what experience do they have in this, they'll say that they see patients who are addicted to opioids or one thing or another, but they do not have the care coordination to do it, or the motivation is lacking for treating these patients because they don't have self-efficacy in addressing this. There were some great suggestions that Andrea noted in her 2018 study, which I know Melissa and HRSA has suggested, of doing mentorship programs with physicians, of having them shadow one another when it comes to induction for treatment. But it really has to come on the timeline that the physician's ready for. A lot of this comes back to their readiness to learn. A lot of people are stuck in their ways. They don't want to change it. But there also needs to be a reformulation in how continuing medical education is provided. And it was really interesting to do this during COVID, when a lot of the physicians that I interviewed actually liked going to conferences and receiving CME in an in-person setting, because at that point their full attention was on the CME. It wasn't on patients. It wasn't on their kids. It wasn't on the million other things that they have to do within the workplace. They were there to learn. One person that I interviewed said that with COVID, they're discouraged from attending anything in person, which leaves us with virtual recorded sessions, which are fine on the surface, but I don't ever make time to sit down and watch the videos. If I'm signed up for a conference, I'm at the conference and you have my full attention because I'm not trying to fix my kid's dinner or anything. So I haven't done any of my CME for 2020 at all. I probably should sit down and do that, which I don't know this individual's requirements, but they probably should sit down and do their CME for this year at some point, since there's only 4 months left in the year. So I think if and it's really hard because I'm not someone who is designing CME. I'm just someone who wanted to look at how CME impacted these physicians' attitudes and barriers to this one thing. But utilizing Malcolm Knoll's 4 concepts of learning really shows that how adults view long-term education. And it really aligns with physicians, like I said, that if they're self-directed, meaning that they dictate, when they want to learn, where they want to learn. Experience, how does CME take a person's experience into the learning environment, and how do we build upon that? Readiness to learn is basically what it sounds. They have to be ready to learn, and then their orientation to learning. How do they how are they going to take that knowledge and then be able to apply it? How are they going to be able to apply it quickly and with self-centeredness and efficiently? And from the data that I conducted, the data that I collected, it showed that this online learning is not helpful, but also the lack of resources that we have in rural Missouri impeded all of these things. And so it was a no-brainer, but I have spent a large amount of my time in the RCORP grant, basically serving as a liaison between all of our partners, our medical providers, our mental health providers, our health departments, and our treatment providers, making sure that the dots from A to D are connected. And if someone is referred from a physician at a Cox Health ER, that provider knows that there's mental health treatment available, that there is respite housing available if the individual is homeless, that there is additional social services if there are children involved. And it takes time, a lot of time, a lot of emails, a lot of phone calls, and prior to COVID, a lot of meetings to make sure that all of those dots aligned for the barriers to be addressed. When it comes to physician attitudes, that's a whole nother ball of wax that is contingent upon a lot of things that I being a cog in the wheel in the health system that I work at, can probably not address. Basically things higher up that I don't get paid enough to tackle. One of the things being patient volume. Another thing being, some physicians are just kind of stuck in their ways. But the research does show that, if all of these things are addressed, and if, physicians have the self-efficacy and the motivation, prescribing for MOUD will increase in a ideal world. And I say that because I know research is done in a vacuum. So that's kind of difficult. I know I talked really fast and that I have 25 more minutes, and this is my last slide. So I'm hoping that there are some questions.